Good afternoon, everyone. Thank you very much, sir, for kind introduction. Before starting my presentation, I would like to thank Sila College of Physicians for giving me this wonderful opportunity to present in front of this prestigious gathering. Let me start with my talk, Back Pain in Young Person, a Challenge to Physicians. I'm Dr. Sujani Jayasinghe, Senior Registrar in Rheumatology and Rehabilitation, currently attached to Rehabilitation Hospital, Raga. I'll be talking on brief introduction to back pain in young person, scenario discussion, and challenges which are faced by physicians. Lower back pain is an emerging problem everywhere, and it's an emerging problem in adolescents too. Incidence is rising and highest in the third decade of life worldwide. There have been multiple risk factors which are identified for lower back pain. Out of those, the obesity, smoking, family history, stress, exercise, and etc. The causes of back pain are various. Out of those, the commonest cause among young people is mechanical. Under mechanical also, the lumbar strain would be the most common one, followed by there are the causes like disc herniation, the probably following trauma related, and congenital disorders like scoliosis or kyphosis. And under non-mechanical spine disease, there are some causes like inflammatory arthritis, infections, and neoplastic causes. So, what is challenge 1? To differentiate mechanical back pain from non-mechanical spinal disease. So, moving to the first scenario, it's a 25-year-old previously healthy IT engineer coming with lower back pain for 1 month duration. It is more towards daytime and worsening with activity, which is improved after good sleep. And how are you going to approach this patient? So, when you are dealing with lower back pain, it's really important to take a proper history and examination. In the history, first you have to differentiate the back pain, whether it is mechanical or inflammatory. So we'll see how to do that. In inflammatory back pain, it's usually subacute onset and which can go on for months. But in mechanical back pain, it's not going for long and it is acute onset. And in inflammatory back pain, there is significant morning stiffness, usually which is more than 30 minutes. And the pain is usually more when the patient is in rest, and there is some improvement of pain with activity. However, in mechanical back pain, the pain is worsened with activity and there is some improvement of pain with rest. And when you are thinking about use of NSAIDs, there is rapid improvement of pain with non-steroid anti-inflammatory drugs. However, in mechanical back pain, though there is a response to NSAIDs, there is no that rapid. And in inflammatory back pain, there is no associated neurological weaknesses. However, in some mechanical back pain, there can be associated neurological deficits. The other important thing is the location of the back pain, where patient can point the lower back. It is basically lumbar or sacral area, or paraspinal muscles, or buttock pain, which is buttock pain may manifest the sacroiliac joint involvement. So there are some other important facts you have to consider in history taking, like the radiation of the pain towards lower limb, and the previous episodes, the duration and the severity of pain, and then the constitutional symptoms. Though these patients are young, still you have to ask about constitutional symptoms like weight loss, loss of appetite, and the fatigue, and sometimes on and off feverishness. Then the spinal or epidural procedures and psychological status also to be uh, considered. So when it comes to examination, you need to expose the patient appropriately and inspect the back properly and see the posture, and start the palpation from the cervical spine to bottom to sacrum, and all the spinous processes and interspinous ligament, the tenderness of the interspinous ligament uh, indicates enthesitis, and then you have to focus on any tender areas in the spine, and then the range of motion of the spine also important uh, when you are considering inflammatory kind of back pain, where the first affected movement is lateral flexion of cervical spine or lumbar spine, and you can perform modified Schauber's test to see lumbar and lumbosacral area flexion. That's how you perform the Schauber's test, and you have to uh, take the measurement, and the measurement should be more than 20 centimeter in normal individual. When it comes to neurological examination, the strength, muscle strength of lower limb, then the ankle and knee reflexes and sensory examination, and the gait should be examined. And when the patient complains of radicular pain, focus on roots, especially L5S1 roots, and you have to do the proper assessment of straight leg bracing test to see radicular pain. And when patient present with acute back pain with some lower limb neurological findings, and never forget to examine anal tone, bladder fullness, that is the uh, palpable bladder, and the subtle anesthesia, which indicating coda equina syndrome. And the other features, like when the history of malignancy is there, and be mindful to examine lymph nodes, breast, prostate, and thyroid. So, in any case of back pain, never forget to focus on red flags, like the history of cancers and the age, but which is not here. We talk about the back pain in youth, and constitutional symptoms, the duration of back pain, which is going more than 1 month, nighttime unresolving pain for usual therapies are the red flags. So here we did history taking, and examination was done, and the following that the diagnosis was made as mechanical type of back pain, and which is lumbar strain. Patient has adequate grounds to say that the lumbar strain, he has sedentary work style, and there are the features she had for mechanical back pain, which is acute pain and the localized pain. There are lower back spasms here. If you see this X-ray lumbosacral spine, you can see the straight spine, and which says there is significant muscle spasms in back muscles. And then the symptoms that are more noticeable with activity, with maybe posture related, lifting things and those things, and pain that improves with rest. So what would be the management? The mainstay of management would be you have to advise for specific lifestyle modification, like the posture maintenance and using of comfortable chair with correct seated posture maintenance, then the adequate analgesics, muscle relaxants, including benzodiazepines and sometimes baclofen, and to prevention of further recurrence and for the treatment, better to advise for physiotherapy as well. So, the challenge 2, we have made the correct diagnosis of mechanical back pain and we managed the patient. And then the challenge 2 is the poor adherence to non-pharmacological strategies, basically physiotherapy and posture maintenance. Though you have properly advised, because of the busy life, they might poorly compliant on that. So that would that would produce the recurrences and the recurrent healthcare admissions and presentations. So let's move on to scenario 2. It's a 32-year-old lady who is a mother of 2 presenting with chronic back pain for 2 years after the second child's birth, and which is attributed to effect of section and which was recently got worsened with significant early morning stiffness and nocturnal pain. Here I have highlighted important facts with red. And so the challenge 3 is early detection of spondyloarthritis. If you don't detect early stage in inflammatory arthritis, which can go on to cause morbidity to the patient. So here, our patient had features of inflammatory backache, the young age, and which is insidious onset. There is significant morning stiffness and improvement of pain with exercise, and the pain experiencing pain with rest. On examination, she had heel enthesitis, that is the inflammation at the ligament and tendon where it is get attached with the bone, and she had significant sacroiliac joint tenderness, and fibers became positive, and which says involvement of sacroiliac joint, and we perform modified Sharpers to check lumbosacral spine motion, which came 18 centimeter. What is expected is 20 centimeter, and the chest expansion and other spinal motions were within normal limits. Then we go ahead with X-ray sacroiliac joint, where she had bilateral grade 2 sacroiliitis, and her inflammatory markers was moderately elevated, and the finally diagnosis was made as axial spondyloarthritis. So these are the some of the technique to check sacroiliitis. Even in busy clinic settings. You can perform the compression and to check the tenderness and the fibers and Gensplin test. This is the technique to check the chest expansion. The normal value is more than 4 centimeter. So in peripheral examination, focus on the synovitis, enthesitis, here the Achilles enthesitis, and then the dactylitis. This is the sausage shape too, and here you can see the psoriatic nail changes as well. So the forms of spondyloarthritis. Spondyloarthritis is a family of disorder, and it's an umbrella term. Under that, basically there are 2 categories: axial spondyloarthritis and peripheral spondyloarthritis. Axial spondyloarthritis, they have the inflammatory type of back pain and some of the other features of axial or peripheral symptoms. And according to the plain radiographic sacroiliac joint manifestations, which again divided into 2, radiographic or non-radiographic axial spondyloarthritis. When the sacroiliac joint, the plain radiographic view suggesting sacroiliitis, which is going to be ankylosing spondylitis. When the X-ray plain radiography doesn't show features of sacroiliitis, it's going to be non-radiographic axial spondyloarthritis. So the other category is peripheral spondyloarthritis, and that they don't have axial manifestations. They only have features of peripheral arthritis. Those are the some of those are the reactive arthritis, IBD-related arthritis, psoriatic arthritis, and so on. Among those chronic back pain, axial spondyloarthritis accounts 0.7 to 5%. So, the diagnosis for that, we can use ASA's classification criteria, where there is the two criteria for axial and the peripheral separately. And for the axial spondyloarthritis, there are two mandatory criteria. One is there is a history should be there for chronic inflammatory type of back pain, age under 45 years old. If this criteria is fulfilling, then you have to see the evidence of sacroiliitis on the radiography, which is the SIJ joint. If that is there, you have to see more than one features for SPA. Under this, there are multiple features of spondyloarthritis. If patient doesn't have features of sacroiliitis on plain radiography, you can go for HLA-B27. If this positivity is there, more than two other SPA features should be there. In addition to, if HLA-B27 negativity is there, you can go ahead with MRI sacroiliac joint as well, where you have to see bone marrow edema. When the patient doesn't have axial manifestations, you have to see the features of peripheral manifestations, which are either arthritis, enthesitis, or dactylitis, plus more than one SPA features in group A and more than two SPA features in group B. When it comes to history examination and investigations, in the history, you have to specifically ask about chronic inflammatory nature of back pain, then the peripheral joint arthritis features, joint swelling, pain, heel pain, and then the finger and toe pain and swelling, suggesting dactylitis, red eyes, blurred vision, and the lacrimation, and visual disturbances, then the rashes suggestive of psoriasis, and the blood and mucus diarrhea suggesting IBD. When it comes to examination, the features of sacroiliitis, that is the SIJ tenderness, the fables, then the arthritis, features of enthesitis, dactylitis, and uveitis. When it comes to investigations, though nearly 50% of patients doesn't have elevated inflammatory markers, but still this is important for the investigations. Then the plain X-ray SIG joint AP view and X-ray spine AP lateral view, and MRI spine here. You have to ask for STIR view especially, otherwise you might miss the diagnosis. Then HLA B27 as well. So, when here I have put some pictures of sacroiliitis in sacroiliac joint, the grade 1 here, and the grade 2, the minimal changes with sclerosis, and the pseudodilatation here, and the sclerosis, and the complete fusion, it is grade 4. Grade 2 higher bilaterally or grade 3 or higher unilaterally is regarded as radiographically positive sacroiliitis. So, what is challenge for? Then we diagnose sacroiliitis, and then the management would be a problem. So, in the management, it's multidisciplinary management coordinated by the rheumatologist should be there. And our primary goal is to maximize short-term or long-term health-related quality of life through controlling joint symptoms, inflammation, prevention of progressive structural damage, and preservation or normalization of function and social participation. So, in the management, basically non-pharmacological and pharmacological, non-pharmacological also very much important as pharmacological. In non-pharmacological management, first of all, you have to teach the patient regarding the disease and the prognosis and the long-term nature and the medication and the drug-related toxicity. Then the other very important thing is you have to inform about the proper exercise. There are several exercises to be advice to the patient. These are posture training and stretching, those kind of exercises, and to improve range of motion. Again, there is another set of exercises and the smoking cessation. Since this is an inflammatory arthritis, there is higher risk of getting into cardiovascular diseases. So the other thing is they have risk of getting pulmonary fibrosis and restriction of the lung, which also again can be got worsened with smoking. In when needed, genetic counseling also to be done. When it comes to pharmacological management, in symptomatic axial spondyloarthritis, you can start with non-steroid anti-inflammatory drug. Start with one drug and gradually maximize the dose to until patient tolerate and the maximum until reach the maximum dose within 2 to 4 weeks, and where you can monitor the response by doing there are the clinical scores, ASDAS and BESDAI kind of scores you can use for that. If a patient is not having adequate response after 1 month, you can switch to another NSAID. So because of the idiosyncratic effect of NSAID, one patient might respond to another category if she is not responded to the previous one. The failing to NSAIDs warrants starting biological TMARs, the anti-TNF1 inhibitor, which is the first line. What is available here is infliximab, golimumab, and adalimumab, and in intraleuterine 17 inhibitors, which is sepukinumab, can be used for especially psoriatic-related axial spondyloarthritis, and this is also available. Janus kinase inhibitors, which is targeted synthetic DMARD, this is again can be used in for the management. When it comes to peripheral spondyloarthritis, as I mentioned in axial spondyloarthritis, like the same way you can use the non-steroid anti-inflammatory drug. Failing two drugs, you can start conventional DMARDs here, like sulfasalazine and LTX, not like in axial spondyloarthritis, where there is no place for conventional DMARDs. Then the failing that, you can move to biological DMARDs or targeted synthetic DMARDs like tofacitinib. So when you talk about the prognosis of the patient, it is generally better when you are considering the rheumatoid arthritis. So, the poor prognostic markers are the peripheral joint involvement, high inflammatory markers, poor response to non-steroidal drugs, and young onset in young age of onset. So, what are the challenges when managing inflammatory arthritis? One major challenge is the poor adherence to home-based regular exercise and physiotherapy, because it is mandatory to make the spinal movements to keep them good. It is very important to follow regular exercise. Then the poor compliance to medication again will be a problem, which can cause recurrent disease relapses. which causing more morbidity, and the non-availability of curable drugs. Up until now, there are no curable drugs. All the drugs which have are disease-modifying drugs. Then side effects of non-steroid anti-inflammatory drugs when you are using for responders, there are no clear guidelines how long those to be used, and in most of the patients we might have to continue those drugs for a long time. So the related side effects also considerable. Then the high cost of biologics, both biologics as well as the targeted synthetic DMARs, both are costly, but out of those, the targeted synthetic DMARs are less comparative to biologics. And the other very important thing is this illness mostly affects to young population, which is mostly contributed for the economic state of the country. So you have to think twice, and it's worthwhile spending high cost to maintain this patient remission, in a remission. So my take-home message is it's a challenge to differentiate mechanical back pain from inflammatory back pain. Good history and examination make it easier. Proper patient education into adherence for regular exercise, physiotherapy, and medication minimize morbidity, and MDT approach, including rheumatologist input, is very much important in the management. These are my references. I would like to thank Ceylon College of Physician President and my trainer, Dr. Dominda Munidas, consultant rheumatologist attached to Rheumatology and Rehabilitation Hospital, Ragama. Thank you very much, sir, for giving me this wonderful opportunity. And my PMD trainer, Dr. R. Hettiarachchi, consultant physician attached to Ragama Teaching Hospital, and Dr. Tilini Hemachandra, acting consultant rheumatology and rehabilitation medicine, currently attached to Rehabilitation Hospital, Digana, and my colleagues at RRH. Thank you for kind listening.